Hi, I'm Sam Gidding. I'm the head of pediatric cardiology at the Nemours Cardiac Center, A.I. DuPont Hospital for Children in Wilmington, Delaware. I've been taking care of children with familial hypercholesterolemia for 3 decades or so, and it's now a very exciting time because there are many new medicines to take care of patients with very high cholesterol, and particularly people who have the homozygous form of the disease. That is, they have 2 genes that give you very high cholesterol, usually higher than 500 milligrams per deciliter. I have the good fortune to be with the premier lipid folk from Kansas City, both Kansas and Missouri, Dr. Geeta Raghavir and Dr. Pat Moriarty, who also have a lot of expertise in this particular disease. What we want to do is get into how you treat homozygous FH and why we think it's important, and a little bit about some of the newer agents. So, since statins are the mainstay of lipid treatment, maybe Geeta, you could tell us a little bit about how you use statins in patients with homozygous FH, particularly kids.
Thank you, Dr. Gidding. I use statins sparingly at this time, but if a kid comes in with a low density lipoprotein cholesterol of over 190 milligram per deciliter, and that persists after adequate dietary and lifestyle changes, we strongly consider statins, especially if they are age 8 years and above. And I'm more concerned about kids who have that high cholesterol and have other risk factors as well, because as we know, by by the age of 13 or even 15, they could have cardiovascular damage. We have research to compelling research to confirm that. So I do have a fair amount of experience treating kids with statins over the past 10 years. FDA approved statin use in children as young as 10 years of age, almost a decade ago, or more than a decade ago, and some of the newer statins are more potent than some of the older statins, and we've used a variety of statins in kids who require it as per recommendations that have been laid out by the American Academy of Pediatrics and the American Heart Association.
I think the problem comes in when you get that very rare child, perhaps 1 in 300,000 or 1 in 500,000, who you see at age 3 or 4 or 5, whose LDL cholesterol is 600 or 700. Then what must he do?
I think those are exceptional cases, and we all have 1 or 2 of those in our practices. And all bets are off in those type of patients. They run the risk of premature cardiovascular disease and mortality as young as age 17 or 18, and we can't wait till they're 10 to begin treatment. I think they should be started on statins, high-dose statins, at the time of diagnosis, and perhaps even be considered for some of the newer therapeutic options, which I'm sure Dr. Moriarty will allude to, in an experimental setting. I think we can't wait. We can't afford to wait in those children.
Well, I've been involved with a patient who's had coronary bypass and aortic valve replacement at age 6. So the disease can be highly malignant, and as you say, all bets are off. So once you've tried statins in these patients and you may knock the numbers down 100 or 200, what might be the next drug you go to, Pat, in a kid and then maybe an adult also?
Well, in the child and adult, I would probably move on to ezetimibe, a cholesterol absorption inhibitor. It seems to be very safe and somewhat effective in lowering LDL by another 20% possibly. Additionally, I might add a Rezinon, because that's also safe. It works in the gut by blocking the reabsorption of bile acids, which are full of cholesterol in the chylomicrons. So that's another possibility, but you're not going to get to goal by that possibility therapy. So that's when he comes in, as Geeta alluded to, is the apheresis, which since 1997 has been a therapy approved in the United States for treating patients with FH, cardiovascular disease, or not cardiovascular disease, on a biweekly therapy. And the guidelines has been an LDL greater than 200 maximum pharmacotherapy with cardiovascular disease, or an LDL greater than 300 milligrams per deciliter without known cardiovascular disease. Just this past year, though, the FDA approved treatment now for LDL is greater than 160 with ongoing cardiovascular disease and maximal pharmacotherapy.
Well, the other thing I've done, I've started genotyping patients a few years ago, and what I found is there's this very heterogeneous response. You can have a homozygous FH patient where I actually had a kid whose LDL went up on statins, and it turned out that he was receptor null for both defects. And I've had other kids who were receptor defective who come down. So I like to genotype the patients because I think it helps me interpret the response to drugs and how quickly I might escalate one drug or another, as well as how quickly I'd get to apheresis. So for the LDL receptor defective patient, I knew apheresis was in her future pretty quickly and got the ball rolling, whereas I got lucky with my receptor defective patient. So this then brings us into getting beyond apheresis. Apheresis obviously is a procedure where you need to be at a specific place every 2 weeks. You're getting used to a machine. How do the patients tolerate that?
It varies. We'd say about 30% might need a fistula because they're vascular, can't take the biweekly therapy of putting a IV needle in every 2 weeks. And we usually use a 16, 18 gauge needle. So that causes problems. And if they're still working, which most of them are, it impedes upon their working schedule and vacation and so forth. So I have a very good staff of nurses that and other team members that kind of assist the patients into working out a kind of a schedule as best we can. But with that being said, it's still a major investment by the patient, by our clinic, and by healthcare itself in the sense of cost. So it's a major investment for treatment.
Now there's lots of new agents available for homozygous FH. They haven't yet been tested in kids in clinical trials, but I know you've been involved in some of the adult trials.
Yes, we were involved with mepomyrcin, which is a antisense antibody or oligonucleotide to ApoB, which is injectable, and it's shown to reduce LDL by 30–40%. And it's been available since, I think, December of 2012. And another one that was approved back around the same time was lumidipide, which is a MTP inhibitor, which it works on the transfer of the cholesterol within the cell itself, either in the intestinal and liver cells, and that lowers LDL by about 50%. Now, that is a pill, but both of those drugs have some significant side effects. If you stop the production of cholesterol, then you're going to build up cholesterol, particularly in the liver, so fatty liver can occur. Liver failure has not been seen with these drugs, but fatty liver can occur. There's injection site reactions and flu-like symptoms with mepomyrcin, and with the lumidipide, there's a little bit of GI complications you have to worry about because it inhibits fat absorption, so you have to worry about that. But basically, they work very effectively. They're not used as excessively as they probably could be, but they've been around and doing somewhat okay. Now, you want me to talk about the next
Why don't
class?
we go on to the PCSK9 inhibitors
Sure.
later,
Okay.
because I think we'd like to wrap up with those. So in terms of right now, in a child, when would you go to Dr. Raghavir, one of these new agents? You'd have to get compassionate use or have to enroll the trial in a child in a clinical trial if they emerge for these drugs. What would be your concern? Who would you start thinking about, not only for these types of therapies, which haven't been tested in kids, but also liver transplant? And how, I guess,
I
ahead.
start off with high-dose statins, knock the LDL low as much as I can, and of course we add estimably. Then that's not very effective in lowering the LDL much more, but there is some lowering which is adjunctive and which is good. Beyond that, I think, as pediatric cardiologist, my experience with the newer agents is fairly limited, and I seek the counsel of, experts in my town and across the country. And I must tell you, at this point in time, we have to weigh the risk of the disease versus the risk of the side effect of a long-term treatment with a relatively unknown agent. And I worry about that even with statins. Giving a kid a high-dose statin for the next 70 years or 80 years is different from treating a 50-year-old with a 10-year. But we have to do what's right, and I guess this is uncharted territory, and there is nothing, nothing written in stone. We have to do studies, and children who are needy and who don't reach goal LDL or are very far away from goal LDL with statins need to be considered for compassionate use or experimental protocols. And I would really defer those treatments to our adult colleagues who have delved into this newer therapeutic agents, which are quite promising, and hopefully they will turn out to be better than statins or more effective than statins in the long run.
Well, for me, the disease progression in the homozygote is key. So I think for Dr. Moriarty, he has, I'm sure a lot of your homozygotes have already had MIs, but for me, when you take an 8-year-old and you do an echo and you see fat on the aortic valve, or you do an MRI of the aorta and you see true atherosclerosis like you'd see in a 40 or 50-year-old in the aorta, or the patient has angina, those are obviously extreme situations. When you might think about a heroic therapy like liver transplant or using some of these newer agents. But I must admit, I'm very concerned about the side effect of fat deposition in the liver in a kid, because again, for the long time you're going to be treating this, and is fat deposition in the liver actually worse for you than fat deposition in your vessels? I'm not really sure. But now the other great treatment that's just been approved are the PCSK9 inhibitors, which work by basically freeing up the LDL receptor. PCSK9 inhibits the LDL receptor, and now we have trials in adults for these agents, and they may be effective in some, but not all patients with homozygous FH. Is that right?
That's correct. A study was done using one of those PCSK9 inhibitors and was published just recently, and they did try it on a group of patients who were homozygote, and they found that a percentage of them show a reduction of LDL by about 30%, and they found those homozygote FH patients actually had LDL receptors that were modest in number, but enough to respond to the PCSK9, which, as you mentioned, it would normally an LDL receptor travels into your liver and it comes back on the surface after depositing cholesterol. It takes about half an hour to do that, and that receptor does it about 150 times because it's a very important protein that's produced and they want to save it. But with PCSK9 degrades that receptor, so you lose that. So these drugs actually make the PCSK9 non-effective in doing what it does and makes the receptors live as much long as they can. So and the drug did get approved just recently by the FDA, not just only for heterozygote, but for homozygote FH. So we do have a fairly safe, and I mean safe, drug that's injectable every 2 weeks, or in the homozygote case, it's once a month. It's a 420 milligram injection. And from my experience so far and everyone else, it's been an extremely positive drug class to do what it needs to do without significant side effects.
Yeah, this brings up a couple really important points for me because I don't think you know exactly how your patients are going to respond. That's why I like to do the genotyping. So if you know somebody is, quote, receptor null, which means they may be much less responsive to the PCSK9, it's important to know that ahead of time. I actually have had pretty good experience with ezetimibe in kids sometimes. I've seen it drop LDLs 200 to 400 in homozygotes, where you don't get the big effect in heterozygotes like that. But another key thing, maybe we should talk about this, is how does liver transplant interact with all this? Because if you have a kid with very aggressive disease, you know that if you can get a liver that does not have FH, the cholesterol will be 150 after you do that liver transplant, but you're living with a liver transplant. And actually, I know that about a third of the kids with homozygous FH in the U.S. right now do have liver transplants.
A third?
A third, yeah. Well, we have a series that we're starting to collect, and I think we believe there's about 90 or 100 pediatric homozygotes identified, of whom we know good clinical information about 40, and about a third of them have been transplanted. So how do you, maybe you can tell us, I think a good summary thing was how do you kind of balance all these treatments now, the apheresis, the newer drugs, who might need a liver transplant. So we now have all the,
Right.
where we had no options, all of a sudden now we have some options.
Right,
But
right,
they all
yeah.
are fraught with some hazard or the
Well-
unknown.
Well, lamidipide was studied in combination with apheresis to show additive benefit and safety, so that seems to show that it works with them. Mifepristone was never studied in a population of apheresis patients. We are presently doing a study with one of the PCSK9 inhibitors, trying to wean our patients off apheresis as we administer the medications to see if we can at least decrease their episodes of therapy or maybe even take them off therapy completely.
Right.
And that study, we just finished our final recruitment, so it should be finished by sometime early next year.
Yeah, that's great. The other thing we really haven't talked about a lot is aortic valve disease, and I don't have a lot of experience with that, but my sense is that there are definitely patients who progress even on LDL lowering therapy. Does that? What's
Yes.
your experience with that?
True, the studies show that lipid-modifying therapy, being statins or ezetimibe and so forth, don't seem to stop that progression of aortic stenosis. There was a recent paper that came out on apheresis that did show it did slow it down more effectively than lipid-modifying therapy, but I don't think it eradicated it because that disease, as you mentioned, just continues to progress in these young
Yeah.
children.
Is
Yeah.
that associated with lipoprotein A levels being high in that population?
Yes,
or-
there's a nice paper that again was just recently published in JACC by Sam Samikinson's group out at UCSD showing that LP(a) is the #1 genetic marker for risk of aortic stenosis. And as mentioning new drugs, they have an antisense oligonucleotide that addresses treating LP(a) by lowering it by 90%.
Yeah, and I think another thing that's important to remember about the homozygous form of the disease is the heterogeneity is huge, so that I was just astonished. I heard a presentation by Dr. Stefanuti, who follows this large group of homozygotes in Italy,
Yeah, Rome.
and she had two patients with LDL levels in the 800s who she'd followed for 20 years, and with serial coronary CTAs, and they had no atherosclerosis, but both needed aortic valve replacements. So there is this aortic valve component, which isn't something that we typically think about with people with high cholesterol. And even in heterozygotes, there's a signal for aortic valve progression. It's just not as dramatic as you see in the homozygotes. So why don't we just get some parting thoughts on the future of homozygous FH treatment?
I think the future is very bright. There are lots of new drugs, and they all need to be studied in children, and that's where we might have a problem, but hopefully we will have more screening, more recognition, early recognition, and early treatments, and more aggressive treatments. But I do think that monitoring disease progression and monitoring side effects, they both have to happen in the same intensity in kids. And as they get older, we are probably going to learn more about the long-term effects and side effects of these therapies in a way that we may not learn by treating adults only. The future is bright.
Yes. And I want to congratulate the FH Foundation for their strong work in these last few years of bringing the awareness out of FH to a much higher level than it's been. It's been in the dark too long, and now it's coming out, that they're realizing that this is not a rare disease, but a very common disease. And as you mentioned, I think the drugs that are coming are very, very promising, and the ones that are here are promising. There was at the ESC meeting in London just 2 weeks ago, they had a PCSK9 inhibitor that was effective for once every 6 months in lowering LDL. So I think the future is bright.
Yeah, no, I agree with you. I think the FH Foundation, beyond raising awareness, has allowed some of these sicker patients to network and get to people who have experience, whether they run an apheresis center like yours or have some experience with kids like myself or Dr. Raghav, So they're turning up on our doorstep now much sooner than they might have turned up earlier. I mean, my sense is when I see a homozygous FH patient it's like I'm diving off a high dive into the deep end of the pool, but on the other hand, it's kind of fun to do that. And I think the future is much more promising than it was. So I think the challenge is in front of us, and we just have to dive off the high dive into the deep end and
If I might add,
make a big splash for the patients.
Dr. Gidding, if I might add, it's a rare disease, relatively rare disease. It might be more common than we think it is. So I think, again, the patient registries are key. So physicians and patients can network. Parent support groups and parent advocacy groups are key. I think that's the only way we learn more about rare diseases, and we're not going to learn them out of more clinical experience or out of textbooks. So I think they might add more strength to optimize the management of these children.
Yeah, the FH registry is going to be big. I mean, even some of the preliminary data mining on the heterozygotes has come up with some fairly astonishing facts, like the age at first MI in a heterozygous FH patient is the same today as it was in 1974 when Dr. Stone published his first natural history paper. So we do have a lot of work to do with this disease. We need a lot of awareness raising. We now have the tools. It's time to get out there and do it. So I'd like to thank my panelists, who are great colleagues also, and hopefully you've learned some more about homozygous FH.